hemifacial spasm. In hemifacial spasm, an ipsilateral neurovascular compression leads to involuntary spasm of the mimic muscles with great impact on the patient's quality of life. The lower retrosigmoid approach is used, which exposes the lower cranial nerve group and the facial nerve exit zone, which starts at the pontomedullary sulcus. Through the retrosigmoid approach, we access the cerebellopontine angle. With optimal positioning, no relevant retraction of the cerebellum is necessary. While using the operative microscope provides excellent illumination and magnification on the operating side, there are still some offending vessels which can be missed because of the blind corners of purely microscopic view. To further improve the field of view and the angle of vision, the surgical endoscope with 45-degree optic is used to visualize the entire course of the facial nerve from the pontomedullary sulcus to the entrance of the internal auditory canal. To gain a subfloccular approach to the lower cerebellopontine angle, a craniotomy and opening of the dura close to the sigmoid sinus after identification of the sigmoid sinus lateral margin is obtained. For preoperative preparation, a thin sliced CT scan of the petrosal area is recommended to assess the course of the sigmoid and transverse sinus, the location of emissary veins, and the pneumatization of mastoid cells. In addition, it is recommended to perform audiometry preoperatively to objectify any deterioration of hearing after surgery. The most common offending vessels of the facial nerve are pica and ica. The facial nerve passes from the cerebellopontine angle together with the vestibulocochlear nerve and the facial nerve much thinner parasympathetic branch, the intermedial nerve, to the internal auditory canal at the skull base. Endoscopically, pica can be identified by a branch of the hypoglossal nerve crossing the artery in the depth. Ica branches off cranially. In some cases, a combined origin of both vessels can be observed. Relevant compression of the facial nerve is usually found close to the brainstem, the root exit zone. The procedure is performed under general anesthesia with the head sharply fixed in the Mayfield clamp. Neuromonitoring for the facial nerve and IEPs are installed. In facial nerve monitoring, hemifacial spasm shows lateral spreads, a sign of abnormal muscle response resulting from ephaptic spread of impulses between the facial motor axons at the site of vascular compression. The patient's head is rotated 45 degrees to the contralateral side. Furthermore, the operating table is tilted 30 degrees to achieve a maximum of retraction of the cerebellum by gravity. For the approach, the surgical area is shaved and the approximated course of the sigmoid and transverse sinus along the anatomical landmarks, the iniomeatal line and the mastoid tip are marked. The sinus knee is usually located in the area of the asterion. The skin is incised in a straight fashion beginning over the sinus knee. The burr hole is placed below the asterion, 1 cm over the mastoid incisura. After removal of the bone flap, the sigmoid sinus margin is exposed with a high-speed drill. In doubt, a Valsalva maneuver can help identifying the sinus. After straight incision of the dura, following the medial margin of the sigmoid sinus, dissection of the arachnoid is started under the operative microscope. With good positioning, the cerebellum folds back after C-sieve drainage, exposing a working corridor between the cerebellum and the skull base without relevant retraction. The arachnoid around the cranial nerves and vessels is carefully dissected. The vestibulocochlear nerve is identified above the inferior cranial nerve group and the jugular foramen leading to the internal auditory canal. The facial nerve is hidden behind the vestibulocochlear nerve. At this point, the view through the microscope is limited by the linear axis of view. The additional use of the operative endoscope with 45-degree optics allows an optimal identification of all nerves, the surrounding vessels, and the relevant compression sites. In the area of compression, a groove in the facial nerve is often detected as a sign of chronic damage and structural remodeling process. After identification of the vessels responsible for the compression and adequate mobilization by arachnoid dissection, a small piece of hand-rolled shredded Teflon is carefully placed to permanently block the contact between the vessel and the affected nerve. Multiple pieces of shredded Teflon may be used to release complex compressions. Teflon is a suitable material for decompression because there is close to no reactive fibrosis. This is particularly important in cases of revision, where the Teflon placed years ago can still be removed completely. After microsurgical insertion of the Teflon, the control of the right position, macroscopic successful decompression, and outruling of any vascular kinking is performed endoscopically. If the linear view on the compression site is poor, Careful improvement of the Teflon position to avoid direct Teflon nerve contact can also be performed endoscopically. Because the endoscope is mainly used for visualization, it is guided by the surgeon itself during the procedure. The surgeon can stabilize the endoscope by keeping it in contact with the dura at the craniotomy. If endoscopic improvement of the Teflon is required, we favor a one-handed procedure with the surgeon guiding the endoscope and the instrument due to the narrow working canal. Only rarely, when bimanual dissection is required, the endoscope is fixed to a mechanical holding arm. On successful decompression, neuromonitoring shows the disappearance of the lateral spreads. For the retreat, the dura is closed in a watertight fashion. In addition, Tacocil is applicated to the dura. Open mastoid cells are closed with muscle and fibrin glue. After multi-layered wound closure, an overhand skin suture is performed. Positioning is the key to successful surgery. The head must be rotated far enough to allow the cerebellum to fall back, while prevention of any compression of the jugular veins, as this significantly increases the vulnerability of the vessels that are manipulated during surgery. For a successful approach, the dura incision has to be close to the sigmoid sinus, otherwise there will be an insufficient visual access to the paramedullary space. Though microsurgical view alone provides perfect illumination and magnification, while still enabling the surgeon to operate two-handedly, especially deep and medial compression locations at the pontomedullary sulcus or hiding behind the lower cranial nerve group are difficult to visualize, but are easily seen when using a 45-degree endoscope. Threaded Teflon placed directly on the decompressed nerve may also cause a recurrence of the spasm. It is important even in cases of very limited space not to position the Teflon on the nerve itself. In case of recurrent spasms, the removal of the previously placed Teflon alone may cause the spasms to disappear. In many cases, mastoid cells are opened during the approach. These cells must be sealed sufficiently with muscle and fibrin glue under the retreat of the dural closure in order to prevent the risk of CSF leak and postoperative meningitis. In case of a CSF leak, rhinoliquorrhea occurs due to the opened mastoidal cells. In case of uncertain findings in the postoperative period, a better trace test or intrathecal administration of fluorescein may be performed. At CSF leak, an elevated upper body position of 30 to 45 degrees and the lumbar drain for several days may be attempted before deciding to perform revision. If possible, the aim is to perform a transposition of the compressing vessel rather than an interposition of Teflon. To achieve successful transposition, 3 options depending on the patient's individual anatomy can be chosen. Most often, insertion of threaded Teflon between the brainstem and the vessel is sufficient for decompression. Alternatively, a Teflon bridge is placed parallel to the brainstem surface between the lower pons and the flocculus, shielding the root exit zone from the compressing vessel. Often, an additional piece of threaded Teflon is placed as a pillar to increase the distance between nerve and vessel. In some cases, due to the tension of high-caliber vessels, a reposition by a Teflon sling is required. After proper arachnoid dissection and mobilization of all compressing vessels, the Teflon sling is placed in combination with a Yazagal clip to fixate the vessel in a sufficient position at the skull base. In these cases, it is even more important to rule out any vascular kinking after performing repositioning. In our series of about 500 MVDs, in 14.5% of cases, patients faced hypoacusis directly postoperative, resulting in permanent anacusis in about 3% and persistent hypoacusis in about 4% of cases. Facial palsy was seen in about 8%, but only around 1% of patients suffered from permanent deficits. Temporary hoarseness as a sign for lower cranial nerve deficit was seen in about 3% of cases. In conclusion, the endoscope-assisted macrovascular decompression in hemifacial spasm is an elegant procedure overcoming the limits of the purely macroscopical view on the compression side, resulting in excellent outcome with a great impact on the patient's quality of life.
Thank you, Professor Schroeder, for that excellent video. My first question to you really regards to your slightly unusual way of positioning the patient. How do you position yourself? Where is the surgeon in relation to the patient in that way?
I sit on the side of the approach. Some people say it's not good. It's better you make this park bench position because then you work 45 degrees downwards. But the retraction of the cerebellum is better in this approach because it falls back by gravity better. When you make this park bench, you have more to retract. So I don't use any retractor. I just cut the arachnoid over the lower cranial nerve group, and then I can mobilize it and the cerebellum goes back. For the patient, the positioning is ideal. For the surgeon, many people are complaining. But I have no problem with it. It's not a long-lasting procedure. And I think the relaxation is very good. So we tilt the head just 45 degrees to have no venous congestion. Then you bring it a little bit up. And then we turn the table, the whole table. There is a support on the chest and the pelvis.
Right.
Then we can rotate the table.
You make a very strong point in your video about the contact between the Teflon pledget and the sponge and the nerve. There should not be any direct Teflon attachment to the nerve. How did you come to discover that idea?
And I think we made 35 recurrent cases. And most of them, the reason for the returning hemifacial spasm was simply the contact between the Teflon and the nerve. In many cases, I just removed the Teflon along the facial nerve. Meanwhile, the offending vessel was fixed by scar formation to the skull base, so it could not fall back. I just removed the Teflon, and that's it. And then the hemifacial spasm stopped. And this occurred in the majority of our recurrent cases.
Interesting. So this was from personal observation that you then modified your practice of not having the direct Teflon contact. Is that different in your mind between the seventh nerve and the fifth nerve? Does it apply also to trigeminal, or is it specifically?
I do usually make a transposition with a sling to mobilize the SCA, put it parallel to the tent, and then I put a Teflon sling and fix it with an aneurysm clip. For me, it is an ideal decompression. Doesn't matter whether it's hemifacial spasm or trigeminal when there's no contact at all between the nerve and any material. And
let's talk about that sling a little bit. You use a Teflon sling, which I find very interesting because
Teflon
some people use Gore-Tex. You use Gore-Tex as well?
Yes.
Okay.
Gore-Tex has a disadvantage that it's very stiff. And when you bring it around the vessel and push, the edge of the sling may vulnerate the wall more. That we had one problem in one case where I put a Gore-Tex sling. It was elongation of the vertebral artery. I put it to the dura, fixed it with an aneurysm clip. It was very nice, but there was a small perforator which was close to it, and because of this traction, it was not perfused, and the patient developed a brainstem infarction. This does not happen in any of the Teflon slings because they are at the edge more soft. No, that is a difference. But for the larger vessels, I usually take Gore-Tex.
What are your tricks about where to attach that sling, specifically to hemifacial spasm?
It depends from many factors. It's an individual anatomy. Where is the sling touching the nerve? Sometimes you can put it a little bit backwards. Sometimes you have to put it more anteriorly. Sometimes there are perforators in a special area where we never can put a sling. So you have to bring the sling more to the back or to the front. So it's always very important that you look for the perforators because these are at risk when you use a sling technique.
I see.
And then it depends from the anatomy. Usually I go in between the internal auditory canal and the jugular foramen, and I make a tunnel in the dura, and then I put one branch of the clip under the dura and the other clip to the sling.
How do you advise your patients regarding the timing of the stoppage of the twitching?
But sometimes, even if I see there is no contact between the vessel and the nerve, sometimes still there's persisting lateral spreads. So what can you do better? Nothing. And then it takes sometimes months until it becomes a good result.
It's very important for younger surgeons to understand that you're not treating to the lateral spread, you're treating to the decompression. And if that the decompression is done fully, then the lateral spread would just have to be what it is. Your endoscope, obviously, that was a big point in your video as well. You use a 45-degree endoscope to look around the corners. Are you using that universally for every case, or is it a case-by-case basis?
Always I use.
Always.
Yes, I want to see down to the pontomedullary sulcus, because that is a way, or that is a location where many offending vessels were missed. Nerve group, sometimes the lower cranial nerve group is it's really like a wall. You can it's difficult to look behind. With 45 degree, you always look without any retraction, and you see down to the pontomedullary sulcus. When you have an endoscope in and you fix it to an holding arm, which is very